Good evening, all. This is our program from TamilNadu Arthroscopy Society, and this is going to be a slightly different one from what we have done before. It's a kind of question answer session, and this thought came to us. We had some 2 weeks ago, we had a meeting from TNAS, and we had good response from our participants asking so many questions. Almost like the whole meeting was full of questions, and then only we thought we should make something differently so that people are interested in question and answers. So we thought we'll select one topic this time and to select one topic each time, like hereafter, like that. So first of all, I would like to thank and welcome our two foreign faculties, international faculties, I can call it as, yeah. One is Dr. Denny Lee. Denny, please show your hand.
Good evening.
Denny is actually from Singapore. I know him for quite a few years. My good friend. He has been to India a few times. He has been to my meeting also once. And thank you, Denny. Thank you for joining us.
Thank you for your kind invitation.
And I'm sure your participation is going to be very helpful for us for the whole meeting. And next is I have Dr. Will Haynes. Will show you. Will is actually heading the shoulder unit at Umhlanga Ridge Orthopedic Clinic. He is actually did his fellowship from Glasgow Royal Infirmary. He did the shoulder and upper limb fellowship there, and he's been a respected faculty member in many local international congresses. And he has done live surgery in our conference also. We know each other very well. And thank you, Will, for joining us today in our TNAS meeting. He was there about a week ago when we made a meeting with Jody Bear also. Welcome to our TNAS conference here. Next is our founder president, Dr. Prof.Arumugam is here. Arumugam, hello, how are you?
Good evening, very well.
Yeah, he's I think seed behind the TamilNadu Arthroscopy Society, and he has joined us for this conference. And our Dr. Ram Chidambaram, President of Shoulder Society of India.
Thank you.
Because it's a shoulder topic, we wanted him.
Yes.
So that, because there is no second thought, we want him to be for the shoulder topic. And Karthik, where is Karthik? Karthik Selvaraj is a consultant from Ortho One Hospital, and he's one of the shoulder man. We needed him also. He accepted straight away to come and join for our meeting. And Sundar, where is Sundar? Oh yeah, Sundar is chief at Ganga Hospital. He's arthroscopy surgeon heading the Ganga Hospital Arthroscopy unit. I don't think he needs introduction. So he's going to contribute a lot for us. And Subair is our secretary for the Arthroscopy Society. And Sandeep has joined. Sandeep Biraris has also joined. Prakash, welcome. And Bhupesh, welcome. Bhupesh and Prakash have done a lot of work for this one. And they are also done homework. They have done a lot for the last 4 or 5 days. And special thing about Prakash is he has got an artistic work in doing a lot of agendas. Welcome, Prakash. So with this small introduction, I have to tell you a little briefly about this meeting. This meeting is going to be totally question and answers. What we have done is, for the last 4 or 5 days, we have asked a lot of our members and others to drop in their questions, whatever they have doubt in regards to the Bankart surgery. And we had an enormous response. Until yesterday evening, we had 35 questions already. And more questions have come today also. And what Bhupesh and Prakash has done is they have kind of divided into categories of which group it belongs to, and they are going to fire questions. And these questions are going to be answered by all our expert panelists. And moreover, Denny and Will Haynes are going to show some of their presentation of some interesting case. And we will also ask all of our panelists like Ram, Sundar, Arumugam, Subair, or Karthik, whoever has got a relevant slide for the questions, please kindly share it also so that it will be helpful for all the participants. And we hope we bring this meeting a fruitful event. The next 1.5 hours is going to be fully question and answers about bankers. So let's finish off the Bankart today from basic to advanced. So with this introduction, I would like to hand over this to our web moderator, Dr. Bhupesh Karthik and Dr. Prakash Ayyadurai, to start firing the questions slowly and gradually and go in-depth discussion of this whole topic. Bhupesh, are you ready to take over the...
Yes, sir.
session. Yeah.
Thank you, sir. Thank you, sir. Again, welcome all our esteemed faculty. So,
Bhupesh, how do you want to go ahead? Go ahead with the questions. Yeah.
yes, sir. So, a lot of questions have already reached us in the last 2 days. We are quickly going to go through the questions, and as live questions start coming, we will start answering those. Directly into the scientific content. The first question was on position and setup. Many surgeons here are lateral surgeons, lateral position surgeons. Now, we want to know the funda behind this lateral position. What are the concepts behind lateral position? So I would request Professor Arumugam to start off the meeting with his answer on this. Shoulder positioning in lateral position, sir. What are your tips?
Yeah, thank you, Bhupesh. Is there any particular question on the lateral decubitus position by the?
Sir, the question per se was given by one of our delegate. Should the patient be positioned in neutral or tilted backward or tilted forward? And what is the rationale behind it?
Okay. So, as you're all aware, there's a constant debate which position is good, lateral decubitus or a beach chair. It all depends upon individual surgeons and your local setup. You know, whatever your team is comfortable with. So I'm not going to go into detail. And I am a lateral decubitus position. I do everything in lateral decubitus. And asking for this for answer for this specific question, we need to negate the scapular angle. So that in order to stick true lateral position, you have to tilt backward so that the plane of the scapula is placed and the glenohumeral joint is parallel to the ground.
Thank you, sir. So, quickly showing a picture of the same. So, what Professor Arumugam had said is a 15 to 20 degree tilt posteriorly. Is this correct, sir?
Yeah, correct. To negate the so that your glenohumeral joint is parallel to the ground.
Thank you, sir. To our esteemed foreign faculty, Dr. Will and Dr. Denny Lie, do you do the same in beach chair? Can labral repair be done in beach chair?
Dr. Bhupesh, yeah, I do labral repairs in beach chair, and actually I find it more anatomical because that is the position that the patient comes to us. What I notice is that in the beach chair position, the labrum, or when the patellus capsule falls off, yeah, you can see it right on the table. So what you see is what you get, and how much you tighten. To me, that's more anatomical and more realistic. So for anterior labrum, it's very amenable. On the beach chair, I can easily do Lartarget or glenoid recon there and then, you know, and the option to open is immediately there. The challenge with the beach chair, of course, is posterior labrum. It's not as easy to do, and one cannot always anticipate be a posterior. So over time, I've sort of gotten used to trying to do posterior on a beach chair. Will, your thoughts?
Will? Dr. Will? Dr. Will, can you hear us?
Unmute him.
Dr. Will, your thoughts on this? Do you do your labrum, anterior labrum in lateral position or in beach chair? Dr. Will, your audio is not clear.
We try.
Yeah.
Okay, I'll just go off the. So yeah, I agree 100% with Denny. I predominantly, the majority of my cases are in beach chair. If I know I'm going in for a circumferential labrum, I may consider performing lateral decubitus. But I trained in beach chair, and exactly as Denny said, the difficulty is the posterior labrum. But what I've found is that sitting the patient up a little bit more vertically than 45 degrees with a bit of anterior translation by my assistant allows me access to that posterior labrum. So if there are surgeons out there who are doing beach chair, that is a tip. Get your assistant to pull the humeral neck forward or anteriorly, and that just gives you a bit more space when working in the posterior labrum.
Thank you, Dr. Will. Dr. Sundararajan, your comments on this. Do you do your labrum in beach chair or in lateral, and why?
I do in lateral positions. Of course, a couple of cases I tried when beach chair position. As Dr. Will said, definitely it is very difficult to assess in the postero-inferior labrum and the posterior labrum by beach chair, at least in my point of view. And my approach to the inferior capsular shift, always I go through the posterolateral portal, and I go through the posterolateral portal and take bites from 7 o'clock position. So for me, it is more convenient in the lateral position so that it opens the inferior space so that you don't have to struggle by going through the antero-inferior portal. So my bite is always through the posterolateral portal. So for me, the lateral position is very comfortable.
Thank you, sir. Dr. K.N.S., you have told me that you started off with beach chair, but now recently, for the past 5-6 years, you have moved on to lateral for instability related work. Can you tell me why? And can you also quickly summarize for our delegates the advantages of each method and the disadvantages of each?
Originally, when I was trained in UK, I had seen mainly in beach chair position only. And hence I was kind of starting to do the beach chair position. And then when I moved on to Canada, there when we were doing fellowship, they were all doing lateral position. So I had an opportunity to see both system, how beach chair position, how lateral. To be honest, somebody who is well trained, I don't think it makes really any difference whether you are doing beach chair or lateral. And it totally depends on individual comfort. And you can do almost everything what you can do in lateral and beach chair also. Similar thing you can do the other way also. There's no difference in that. Almost you can do everything. But in what way I found myself comfortable here in doing lateral position is putting an end-on view or from the anterior portal in lateral position. I found it much more visible than the beach chair position. For some reason, I don't know. And then next is you can get more abduction in lateral position. If you want to, you can actually get your some kind of traction over the proximal arm and try to get more abduction. So the most important stitch for our Bankart repair is going to be inferior capsular stitch. For achieving that, as either you can go through the posterolateral portal or you can even go to the anterior portal, but we need visibility. For getting visibility, that lateral position is slight extra abduction will really help out. Another thing is in terms of anesthesia purpose. For example, lot of anesthetists actually, I know there is pros and cons of both beach chair and lateral. And so anesthetists prefer lateral for in terms of having complications. Okay, less number of, I mean, though the complications are very little in both positions, beach chair or lateral, in comparing edge to edge, there may be slightly higher incidence of complications in beach chair. Hence, people try to prefer, at least in a smaller setups, not in a bigger corporate setup where every facility is available. You don't need to worry about these complications at all. It will be almost equally same. But in a smaller setups where lateral position may be much comfortable the anesthetists feel. That is another main reason I started doing the lateral position.
Thank you, sir. Thank you. So to just quickly summarize what you have said, beach chair is easy because it looks more anatomical and you can convert and open and do an open procedure. But mobility of the limb is a problem. Posterior labrum is a problem. Of course, you need the special attachment and the head holder and hypotensive anesthesia. There is always a risk with decreased cerebral blood flow and problems. And as you have already mentioned all this, lateral is familiar, limb and traction, so no special attachments required and very minimal anesthesia related risk. So we are going to the next question. This is on, again, positioning and setup. Can we give intra-articular adrenaline regularly few minutes before inserting the scope? So this is the question that I've got. And Dr. Karthik Selvaraj, can you take the question? Do you give adrenaline? Dr. Karthik, you are not audible. Karthik, Dr. Karthik Selvaraj. Okay, Dr.Subair Khan, meanwhile, can you take the question? Do you use intra-articular adrenaline?
No, when come for Bankart, we don't use intra-articular adrenaline. The main thing in the anesthesia part is we first give a block before intubation. So once the block is done before the positioning, then we put the patient into intubation. So we generally use tranexamic acid, tropic. So that gives a lot of visualization, better visualization, and even the bleeding is also less. But generally, I don't use adrenaline in our practice.
Okay.
Bhupesh?
Dr. Sundararajan, can you give your comments on that? Do you use intra-articular adrenaline?
No, we don't give in any shoulder pathology is because especially in the Bankart, the worry of bleeding is happening only when you are separating the labrum from the glenoid. So only in that moment when you separate it, completely from the medial neck, then especially when you go in the end, then you get some bleeding over there. Of course, it stops in 1 or 2 minutes. If you wait for 2 minutes, I think that bleeding will automatically stop. The remaining rest of the procedure in Bankart or Remplissage, you are not going to have any bleeding over there. So I don't think it requires in a Bankart surgery with reasonable blood pressure by anesthetist control. I don't think I don't think you should worry about the bleeding in the Bankart surgery. In my opinion, I think it's not required.
Can you hear me? Bhupesh, can you hear me?
Yes, Dr. Karthik. Yeah, please tell me.
Okay. We do two things here. One is we add, because a lot of local anesthetic has already been given in the block, we infiltrate the portal sites with adrenaline, 2 drops of adrenaline, 20 ml of saline. We just infiltrate the portal sites so that the portal sites don't bleed. And suppose in patients whom there is the BP is not controllable and there is a lot of bleeding, there is a readout, you can't raise you don't have access to a pump. Then in such case, if there is a lot of bleeding inside, what we do is we add some adrenaline into the fluid, into the irrigation fluid. So that does help to some extent to control the bleeding temporarily. One small problem with that is if the patient is hypertensive, then that irrigation fluid adrenaline can slowly start increasing the BP of the patient. So as a temporary measure, you can add adrenaline into the irrigation fluid. The other thing is just infiltrate the portal sites. You don't need to give it, as Dr. Sundar and others said, you don't need to inject it intra-articularly. But if somebody wants to do it, there is no harm in doing it.
So thank you, Dr. Sundararajan. K.N.S. sir?
That is Karthik. Can I add one point?
Dr. Karthik.
Okay, can I add one point?
Sir, please.
So see, I think the bleeding problem usually comes if you do it in acute situations, like ACL surgery. The patient had acute dislocation, and if you try to operate within a week or 10 days, then you are going to have a problem. And the other problem where you can have in a problem where the patient has got a chronic issues, if the patient have associated issues like a synovitis, and which you have to be carefully, you can rule out by doing an MRI scan. Having a recent MRI scan even before surgery will rule out that kind of synovitis stage, but that is very rare. Unless the patient has got some stiffness, then they may have a synovitis, then this patient can bleed more. And other point is, which I told, in acute situation, better not to operate in that first 2-3 weeks time, so you will tend to have more bleeding. For the beginners, maybe these points will be helpful.
For somebody who is just beginning, if they don't have a pump and if they don't have a proper RF, like if they start with some underwater cautery or something like that, that's when they encounter some sort of bleeding. So it's a small trick.
Yeah. Subramaniam, Dr. Palanivel Rajan sir has come. Like you to invite.
Dr. Palanivel Rajan has just joined. He's
hi.
Screening. How are you?
Fine.
Ram wants to add one point. Yes, Ram.
Just one point, because I operate for acute system dislocator within a week. So I don't think that bleeding because of the fresh injury is a big issue. I think the main key thing what we are talking about here is to get the systolic blood pressure under control. That is the main source.
Ram, for you, everything is easy.
No. I just said the systolic blood pressure under control will give a better view, because this particular instability surgery, as you said, it's only intra-articular. So only certain few steps only there is a point to bleed.
Bleeding issues are more common in
in the rotator cuff repair surgery.
Yeah, it gets cleared off. It's like ACL. After 2-3 minutes, that bleeding will go off. But still, for the beginners, I think the visualization will be a problem. Then they should not struggle for where are the structures. So I think for the beginners, better to wait for 2-3 weeks to do the like how we advise for a ACL surgery.
Safe play. Safe play.
Yeah. Sir, thank you, sir. So now I'm getting into more controversies. So pump. Do we use the pump? Do we not use the pump? Because I know few here don't use the pump. Few use the pump. And what is the pressure that we use? And what is your flow rate? I think there's a difference between the beach chair users and the lateral users. I would like all the faculties to take the question, starting with Professor Denny Lie.
Yeah, so I use the pump routinely. For bank labor repair, I think the pressure doesn't need to be high. I'm just happy with 40 to 60. Yeah, and I don't always use adrenaline as what we discussed previously. So for me, pump is routine. Bhupesh.
Dr.Will?
Yeah, I also use a pump routinely, and my answer to the number is the lowest possible pressure to be able to see clearly. So I start between 20 and 40 like Prof, and you know, in the event that you need to ramp it up, I will ramp it up.
Perfect. Prof.Arumugam?
Yeah, I always use a pump and don't use adrenaline. And the pressure, I start with low because you don't need a big pressure for the labral repair. Only with the cuff, you need a higher pressure. Start with 25, 30, and that you'll be able to manage. But if certain steps, if there is a bleed, then momentarily increase the pressure, but immediately bring it back.
Okay. Any difference here? Any faculty here not using pump for Bankart repair? Dr. K.N.S., yes.
You know, I used to use the pump. For 3-4 years now, I'm not using it. And we know the step when it's going to bleed. So those steps only you kind of use your cuff and just pump a little bit, that's all. Remaining step, you don't need pump at all. You have your height of the IV stand about half meter height, then you will get about 35 to 40 mm pressure normally. So normally if you raise the IV stand to 1 meter from your shoulder level, then it's going to give 77 mm of pressure. That is a conventional measurements. Okay, if you raise to about half a meter, like 50 centimeters, then you get about 30 millimeters pressure. So I use that kind of thing for most of the time. And when you are doing liberating the labrum, that where it's going to bleed, I just do a little bit of pumping at that time. That's all.
Thank you, sir.
For doing Bankart, I stopped using pump nowadays. Not using pump at all.
Thank you, sir. Thank you. So very quickly, we are going to the next question. We have from the fancy Spider. We have the good old 3-point traction system, and of course, some people are happy to operate with the IV stand on. So very quickly, starting from Dr. K.N.S, sir, what is your preferred suspension device and why?
Sorry, I think you started in the wrong way. I don't use any fancy device, first of all. Okay, yeah. And I don't use traction. I only use some abduction. So abduction for a Bankart will be around 60 to 70 degree. For a cuff will be around 40 degree. So less abduction for cuff, more abduction for Bankart. And it will be just hanging on a IV stand. That's all. IV stand where you tie it on the operating table, and just tie your with the help of a stockinette, tie with a bandage and attach it to the IV stand. That's all I do.
On the same side or on the other side?
I found myself not very big different from attaching other side and same side. So I do the same side only.
Yeah. Okay, sir. So Dr. Palanivel Rajan, sir. Sir, you have to unmute yourself, sir. Palanivel, sir. Unmute.
Yeah, I use a 3-point traction, which makes life quite easy because you can give traction in both directions. Just you can lift the head as well as you can give a traction. And regarding pressure, I keep it around 30 to 35. I always use a pump, and very rarely we get more bleeding in case of a fracture. When you have a glenoid fracture and then you have to fix it in a very, very early stage, then I sometimes use adrenaline to keep the visualization better. And for the position, I think what K.N. has said, like 70 degrees, I give traction, and I think that makes life better, even for the beginners also.
Thank you, sir. Dr.Karthik Selvaraj, you were going to say something about
No, I was just about to ask Dr. Subramanian if in a very bulky muscular patient, if you have any trouble in distracting, what are the tips and tricks while using a IV stent?
Sure. So in a muscular individual, the only problem is you will not be able to get your abduction. So what you can do is you can put an extra, some kind of support over in the axillary region.
Like axillary bolster sort of thing.
You put over there and ask your assistant to try to lift it off when you are reaching that stage. So that is the only additional step I do when you are having such kind of obese patients and all.
Yeah. Any other faculties have got difference in here? Yes, Dr. Denny, please.
Can I be the devil's advocate at this point? I don't use any traction because on a beach chair, gravity does the job.
Yeah.
So think about beach chair, guys. So you get your assistant, they can do rotations for you, slight abduction on a Mayo table. Hey, it's free. So just my thought, I don't use any traction, Bhupesh.
Yeah, thank you, sir. Dr. Will, yourself?
So I do use traction, Denny. So interestingly, you make a very valid point, because a few weeks ago, prior to the lockdown here in South Africa, we ran out of consumables for the traction, the spider traction that I use. So we weren't able to use it. So I was forced to use the Mayo table, and it worked particularly well. So I may be changing my technique.
Professor Arumugam?
Yeah, I use a spider because I find, especially when you have athletic population with a very good muscle tone, then need have some amount of traction. Then we need to have a controlled traction. There, I feel in this kind of device. I also use 3-point distraction, but now I am kind of quite happy with the spider instrumentation.
Thank you, sir. Dr. Ram Chidambaram, sir, yourself?
I think the choice is mostly what you are trained with and what is available. So my position is lateral decubitus with a 3-point traction with a lateral arm traction. So lateral arm traction, I find it very useful for the instability work. So that's my practice.
Thank you, sir. Thank you. So the next question quickly to all faculty, we'll start with Dr. Sundararajan here. Sir,
Okay.
have you seen neural injury, traction injury? And is it a very serious thing that we should consider? How long can the hand be suspended in traction?
Yeah. So for the lateral position for the Bankart, so far luckily I never had any nerve injury, but I had one traction injury, brachial plexus neuroplexia, which I operated for a synovitis. I don't know, my initial part of career maybe around 7-8 years before. But that procedure was only maybe around 30 minutes or 40 minutes. But it was in the lateral position, I'm sure. But I didn't usually know, our technician puts the weights over there for the traction. At that time, you don't particularly see how much traction is there, what is the position. So everything is draped, you go and operate. Really, still now, I am not able to find out the reason for that brachial plexus neuroplexia, which had happened after the surgery in the lateral position. That is the only one case which I had it in 8 years before, and it took almost 11 months to recover completely. But it recovered completely, but it took 11 months. But it is a horrible time to talk to the patient every month. I really had a tough time. Probably the over traction, that's what I feel still. But maybe the neck might have been hyperextended by the anesthetist. We don't know. So which is the 2 points which you have to be very, very careful when even though positioning before you drape, at least you or your assistant should go and see that neck is not hyperextended and your traction is within the limits is very, very important.
Perfect. Thank you, sir. We are quickly going to the next question. We'd like to discuss more. So this is one question by one of our friends. What do you do when your light source fails during a case? Apparently, he had such a bad scenario. Dr. Subair Khan, would you like to take that question quickly?
Yeah, this happens when, most of the time it can happen when the freelancing surgeon do a lot of surgeries outside. We have faced it before. The only thing is to have a backup. So if there is a failure of any device, in fact, not only the light source, even if your camera or anything goes on in between, you definitely need to have a backup. So for any technically aspect, the backup should be there for everything. Otherwise, you can't do the surgery.
Point well taken, sir. Point well taken. So now quickly to another set of questions. First question to Professor Arumugam. Young first-time dislocator, will you wait or operate immediately? Is there a role for conservative? Sir?
Yeah. Young, how young? What is the age, Bhupesh?
Sir, 20 years, less than 20 years.
Okay. So, and what kind of profession is athletic and contact sports, or what is this?
We'll include an athlete, sir.
I'm sorry?
An athletic population, first-time dislocator, college athlete.
Is it contact sports or non-contact sports?
Sir, contact sports.
I mean, if it is a first-time dislocator, it's always the point of debate. And I'll see if it's a contact athlete and is that needs he has to participate in sports immediately, then I'm going to operate, stabilize the shoulder joint. Otherwise, I would wait. I would not go in.
Okay, sir. So, we'll second question to you, Dr. Will. Elderly first-time dislocator, what will you do?
Elderly first-time dislocator, I would be more inclined to be conservative and observe, give them a trial of physiotherapy, rehabilitation, review at 6 weeks. I wouldn't offer them surgery.
Okay. Now, the next question to Dr. Sundararajan. Relocation of dislocation in the casualty. Will you do it under anesthesia, without anesthesia, and any rationale?
Okay. Can I add one point to the previous question also?
Yes, sir,
Because
please.
a lot of beginners are there. So whenever you see an elderly dislocator, the most important is, I mean, I know because we had shown that we do conservative treatment for first-time dislocator, but we had to be very careful and seeing these patients in the follow-up to rule out any cuff tears. That is a very important point, because for the beginners, we may think that, okay, after 2 weeks strap, we go to the local doctor, remove the strap and move the shoulder. Then the patient may have a cuff tear. Then we may neglect that, or they may come later for the surgery. So these patients, on the other point, should be taken care that whether patient has cuff tear or not in the further follow-up. You don't need an MRI on the first time, but in the further follow-up, just we can give a caution that we may need to do a further clinical examination in that point in that patients. Like a first-time dislocator, which you say for the first-time dislocator in the casualty, in our institution, we don't do any procedure in the casualty because of our institution. So we do under the block in the theater.
Okay. Any difference in opinion in this, Dr. Ram Chidambaram?
I agree. I think it's highly pointed out. First-time dislocator, you could discuss the option with the patient. It depends on the practice. In my practice, I offer surgery during the same admission within 4 or 5 days time if they opted for surgery, if not conservative. The elderly dislocator, yes, agree, it is a rotator cuff tear problem. So it has to be a trial of conservative unless it's a relatively younger age. The last question, yes, agree, it's anesthesia reduction.
Thank you, sir. So next question, anterior portal placement. Many of our delegates have asked this question. This is the question which had the maximum number of queries. Professor Arumugam, can you talk to us about anterior portal placement, some of the tricks and tips on how to place it well?
Yeah. For the Bankart repair, the portal placement is a key. And I always use the 3 portal. That is one viewing portal, which is the posterior portal, and 2 anterior portal, one antero-inferior portal and antero-superior portal. I started with only 2 portal because most of us, when we started initially, that's the problem when you looking at from beginning and doing all the procedure anteriorly. Sometimes the lesion, like abscess lesion, you won't see the labrum at all. So you have to do the antero-superior portal for viewing. So you have a bird's eye view of the entire labrum, and use both portal anterior and posterior for passing sutures, and so that easy. And always, as you all know, you have 2 ways you can make the portal: inside out and outside in. So inside out, no, we should not do it, because there you cannot point the how the portal placement and the point of entry. You always use outside in technique using the needle, spinal needle, so that when you putting the needle, you can always check the angle of insertion of your anchor, as well as where you can reach. I think, Bhupesh, you have a video for this. If you can play that video.
Yes, sir. I will quickly.
easier for them to understand. So
Or you can explain as the video goes, sir.
yeah, share.
One second, sir.
You don't see the video. You want to share my screen? I'll do that then.
Yes, sir. This I've
Okay.
shared.
Okay, fine. So as you can see here, this is the antero-inferior portal, just lateral to the coracoid, and you have to go to the triangle between the subscap and the biceps and see the needle. You can reach all your point, and you should come eye in the triangle in the apex here. So the angle of insertion is good. Then here is antero-superior portal, just close to the biceps. And you make the incision on the here with the knife longitudinal along the fibers of the rotator cuff, so you don't cut the damage the cuff. So it's very critical making those two portals. Once you do this, you first a spinal needle, then use a scalpel. Make sure you kind of use the plastic scalpel so that it doesn't dislodge. Sometimes the blade can dislodge into the joint. Another one problem is crowding of cannula. What a common problem we encounter, like because you need an antero-inferior portal, you need a big working cannula, 8.25 cannula. So the antero-superior portal, I don't use the cannula, and I just use the metal cannula, the metal operator, so that it is not damaging to the cuff muscles. And sometimes you may go behind the biceps, so that there's no crowding of the portals and cannula.
So thank you, sir. Dr. Will, I'm sure beach chair is a little different from this. How do you do your portals in beach chair? Can you talk to us on that?
So yeah,
you can share your screen if you have.
Okay, I'll do that now. Okay. Right, share that. That should be coming right now. That one there. Okay. So what is your landmarks are similar, and I'm exactly the same. I view from posterior initially, and then I'll develop an anterior superior portal, which I like to put exactly as behind the long head of biceps. And then with at least a 4 centimeter skin bridge, I will then put my anterior inferior just coming over the top of subscapularis. So there's my posterior. With my experience and time now, I've erred towards having a slightly higher posterior portal. So not quite the 2.5 centimeters from the tip of the posterior acromion. I err more to being sort of 2 centimeters medial and 2 centimeters inferior as opposed to the 2.5. It just gives me a slightly better view. Not really talking about Navisa. So the anterior portals that we're seeing here will be anterior superior. That's just coming across the just around the long head of biceps, and then my inferior anterior.
We can hear you, Dr. Will.
Yeah. Can you see the video? Did you see the video? The screen, is that coming through?
Yeah.
We can see you very well, Dr. Will.
We're listening to you.
Super. Yeah. Okay. Yeah. So I think is there more? There would be my lateral portals. Not really. That would be more rotator cuff related. In terms of the Navisa portal, I only use that for when I have like a type slap 5 tear that's associated with a Bankart tear. Not always the easiest portal to work with. And maybe Prof. Denny, have you got any sort of maybe tips? Yeah, it's one of those portals that I find once you create, you tend to crowd that superior labrum. Possibly you've got a tip or a trick to make it an easier working portal?
So I tend to use a very high anterior superior portal. That is useful for both a suture management in a typical Bankart, and then I can flip it behind the biceps. It's very useful for slap. So I don't always use the Navasio portal for Bankart repairs, but there's just slight differences in the anterior superior portal. And then you can use it for a slap as well.
Thank you, Dr. Denny. So to get back to this, we have another question. Dr. Sundararajan, your thoughts on this? 2 anterior portal versus 1 anterior portal.
Sir, just I muted. 2 anterior portal versus 1 anterior portal means there's only 2 portals, one from posterior, one from anterior.
Exactly.
Right.
There are some French surgeons who do it, Jean Penny and his team,
Yes,
with
yes.
only 1 anterior portal.
Yeah.
And, do you advocate it?
Yes, Professor Arumugam also told, no, when he started with the 2 portals, that means 1 posterior and 1 anterior. And then people started using 3 portals, 1 posterior and 1 antero-superior and 1 antero-inferior, and started working again through the antero-inferior, antero-superior for the suture management and the working part, and seeing through the posterior portal. But now we had come to the next stage where we see through the anterior superior portal, which was pointed out by the previous Subra or somebody, where you get that beautiful end-on view, which you see through the anterior superior view. So your working portal will be an antero-inferior portal, and suture management can be done through the posterior portal, so that you can do that your mobilization of the labrum very nicely by seeing through the antero-superior portal, so that you can see all around the inferior glenoid up to 7 o'clock. You can mobilize the labrum very well. So I would suggest that whoever start, I don't think nowadays nobody does 2 portals, like only 1 anterior, 1 posterior. Always we do 3 portals, like 1 antero-superior, 1 antero-inferior. And maybe the visualization, maybe you can see through the posterior also, but I think working through the anterior part of the middle part of the neck is a bit difficult to see the labrum. If you have a big ulcer lesion, by seeing through the posterior portal and mobilizing it is a bit tough. So when you see through the anterior superior portal, you have a very good tendon view, and I think it works well for all your anchor placement and your suture management. And I think everything is better by 3 portals.
Sir, thank you, sir. Thank you. I think that was very clear. And I will skip the central question because Professor Arumugam already answered, saying not to do inside out technique for the anterior portals. So that
we add one thing, for the beginners, this making portal is the most important step for the, if you don't be in a hurry, take your time, take your portal right way. If you do it right way, half your job is done. And otherwise, throughout the procedure, the angle won't be there, the crowding of your portals, a lot of frustration. So take your time in making portal, and outside in technique is the way to go.
Sir, thank you, sir. To sum it up, I think outside in is the way to do, and we should avoid overcrowding. And ideally, the angle between your scope and your instrument portal should be 30 degrees between the antero-superior and antero-inferior. So you have a good trajectory to do your work. Quickly going to the next questions. Portal placement for slap. Very quickly, Dr. Will touched upon this. Dr. Karthik Selvaraj, would you like to share your slides on this and tell us more on, when many times you have Bankart with slap, and how do you tackle that situation? Dr. Karthik?
Can you see my screen?
Yeah, yes.
As far as slap is concerned, I think all of us now agree that the incidence of isolated slap repairs have come down, unless it is a type 2 slap, especially in a patient who's non-athletic, not a very high-level athlete, who has typical slap type symptoms, no other pathology in the shoulder, then a slap repair is indicated. Otherwise, we for elite athletes, we do biceps tenodesis, most of the time subpectoral. And when we do that, you can actually put an anchor on the superior labrum. There is a theoretical possibility of spinal glenoid not cyst developing later if you leave the slap tear there. So you can do a labral repair and then also do bicep stenosis, because if you do that, then the return to sport is better in this age group. So when you have a slap tear, there are a couple of ways in which you can address it. So you can either work from your anterior portals and view from the posterior portal like you always do, or you can actually work from your posterior portal and view from the antero-inferior portal. So you make the portals just like you normally make your posterior and the anterior inferior portals. And then what I now do is I switch my scope to the anterior inferior portal. So when you view from the anterior inferior portal, you get a beautiful view of the slap tear. And just a minute, I'll just let's see if I can make this video here.
Karthik, do you in beach chair position or lateral decubitus?
Lateral, sir. Lateral. All my labral work in lateral position. So say this is a see nowadays this repair of the postero-superior labrum mostly we do for spinogleena not cyst like this. When we see a patient like this who has a posterior superior labral tear along with a spinogleena not cyst, you can see this cyst sitting just exactly in the posterior superior area. So you go intra-articularly, elevate the labrum. So here if you see, sorry for the quality, this is an old video. So here if you see my shaver is coming from the
Video is not running.
yeah, my shaver is coming from the posterior portal.
Your video is not running. Can you
Karthik.
Is it not running?
Ama, video is not running, Karthik.
Is it running now?
No.
It's not running. Can you otherwise give a comprehensive view on what are all the portals you use, how to approach, where you take the bite, like that?
Yeah, so no, I thought this will. So you can't see my screen?
I think the net issue.
Karthik, but is not running.
Okay, so so you switch your. I switch my viewing portal to the anterior inferior portal, and then I introduce my elevator from the posterior portal. So from the posterior portal, I can actually elevate it along the postero-superior area, and then I make a antero-superior portal slightly more lateral than normal. It is not a very lateral portal like Port of Wilmington, but it is a little more lateral than exactly at the level of the biceps where we make for our labral repair. So when you make that portal, you can actually put your anchor through that portal. And also I use a bird beak kind of device from that portal itself and take a bite through that same portal. So it's usually a 1.8 or 1.9 mm all suture anchor with a very low profile knot on top. So usually a double loaded suture anchor, and then you tie both the knots on top. So that's the way I do it. And I'm sorry if the video is not running. So that's it.
Thank you. Just unshare your screen, Dr. Karthik. Yeah. So to sum it up, Dr. Karthik said he will view from antero-inferior, use the posterior portal, and with the posterior portal, elevate the postero-superior aspect of the slab. Go back and with your slightly lateral antero-superior portal, put in your anchor. Also do the preparation of the anterior part of the slab, and through the same portal, with your bird beak, you can retrieve your suture and tie knots to the same slightly anterior antero-superior, slightly lateral antero-superior portal. Am I correct, Karthik?
Yes, that portal is through the cuff. So when it is through the cuff, you need to understand. You can't. The way to avoid injury to the tendon is you have to come a little medial so that you are through the muscle. So you have to actually do that in a little bit of a less of an abduction so that you actually don't injure the tendon.
Thank you. Thank you, Dr. Karthik. So there are a couple of questions on labral lesions. What if I felt that the labrum was already healing? How much should I release? And once I saw a chondral defect with the labral tear, what should I do? And what if there is a slap or posterior labral tear? So to answer all this, I will quickly ask our President, Dr. K.N.Subramanian, to show us some slides on types of labral lesions so that it will be useful for everybody. You have to share your screen from the Zoom, sir.
I'm just going. you able to see it? Or?
Yes, sir. To play now.
1 minute. Are you able to see the?
We are able to see, sir. You have to click on play.
You know, this one, what I'm just showing now is somebody, if you can see the labrum there, marked as a labrum, the glenoid margin is over here. And this labrum actually should have been over in the glenoid edge, but it has displaced far medially, almost quite deep, almost 1 centimeter deep. This is a typical type of Alpha type of lesion, where you find that the whole labrum and periosteum has gone down far deep. And I just see whether the video is working or not. Let's just see. Are you able to see the video working?
Yeah.
So can you see that labrum there? That labrum is actually far deep, and it is a typical Alpha type of lesion. And the only way you can find out whether the labrum is there or not is only by liberating. If you don't liberate the labrum, you will totally miss the lesion. You have to go far down right up to 6 o'clock and liberate it. Okay, so that is so once you liberate it, you see that labrum is floating out. That is one type of lesion. I'll just show. There is one more where I have with multiple dislocations and number of dislocations with labral appearance. I'll just try to show that one. Can you come back to this question again? I'll just take it and come back to you. Okay, yeah, Bhupesh? Because he's in another.
Sir, can you unshare the screen?
I'll unshare and come back to you in about 2-3 minutes time. Okay, yeah.
Perfect. Meanwhile, I would ask, sir, you have to unshare your screen, sir.
Yeah, yeah. I'm doing stop sharing. I put it. Okay, yeah.
So yeah. Now I would request Dr. Denny Lie to show his slides on how to avoid missed lesions.
Bhupesh, you want me to start with the
missed lesions? Yes, sir.
Okay, let me share my screen on. Okay, yeah. Can you see this?
Yes.
All right, so here I'm going to talk about chronic lock anterior dislocation that was missed. You would have thought that, hey, that's not easy to miss, but it happened. So let me share this case with you. Classic 40-year-old desk-bound job, plays soccer recreationally. So he fell on an overseas trip, and that is his X-ray. Yeah, as you can see, and it looks really benign. And I really wouldn't fault anybody for missing that based on that X-ray. He was seen at the A&E at another hospital, told there was nothing wrong, and sent off. The key thing was that his examination showed a limited forward flexion, abduction, somewhat limited, and it's just not right. So the teaching that I gave to my residents using this case was that you need the other view. So you really use views, and then in the end, when we did an MRI, lo and behold, it was kind of locked anteriorly. Yeah, you can see that very clearly on MRI. But if I go back, the X-ray looks particularly benign. So really, it's the multiple views on X-rays, and if you can, MRI would show you that problem. So now the question is, with this kind of MRI, what would we do? Bhupesh, do you want me to discuss with the rest of the faculty?
Yeah, yes, sir. Please go ahead, sir. It would be interactive.
Yeah, so I can open it up to our friends, all the faculty. What would you do when you see this kind of chronic lock anterior dislocation? It's not so bad. The Hill sacc is not that deep, although it's completely engaged locked anterior. Do we want to do a close reduction in the arthroscopic repair? Close reduction, glenoid recon, open reduction, labral repair alone, open reduction, fill up the Hill saccs with an allograft. Can I invite Dr. Sundararajan?
Can you show that X-ray again? Don't mind.
Yeah, this is the MRI, which is self-evident. These are the X-rays.
And how many weeks now since the dislocation?
It's been a couple of weeks. I can't remember the details. He fell when overseas. This was his ROM all this while until he saw us. And then we just went straight to MRI.
I think it's a very difficult situation. So we encounter these kind of patients a few times because neglected anterior dislocation of the shoulder. I think, the first option, of course, it is almost ruled out. We cannot do a close reduction. So these patients always require a open reduction. So you are coming to the option only 3 and 4 all the time, unless the patient comes to you in a very first few days of the injury. So always these patients will come as a few months together. Then even especially in India, they'll go to the native treatment, put an oil bandage, and they will come very late, like 3 months, 6 months. So what we do, I think, what we do, at least we do open reduction because it's not possible. So we give a general anesthesia, we do a open reduction, and depending upon and we check for the stability. So always is a problem here. Stability is the major issue over here. So depending upon the bone loss, unless if it is a huge glenoid bone loss, I don't think this case doesn't have that much bone loss as far as the
Not on the glenoid side. Yeah, it's really the Hill sacks that we need to address.
Basically,
so, yeah, thank you very much, Dr. Sundar.
Yeah,
I choose option 4. So my thinking very similar to yours. I realized that I cannot reduce chronic locked close, and I needed to do it open. So the question is labral repair alone enough? Because the glenoid stock looks good. I don't need to recreate it. So the question is it soft tissue enough, or do I need to address the Hill sacks? And how do I do that? So for me, in such cases, I reconstruct the cavity of the Hill sacks with an allograft. I don't think a remplissage alone is enough. So I'll just show you the pictures I did. That's what I saw, that huge, deep Hill sacks, which I measure. And I use femoral allograft. It's important to avoid the superior part of the allograft, which is the most weight bearing. And that tends to sort of degenerate over time, even if it's an allograft. So I use the sort of the circumference, the equator part, which is a little bit stronger, which is what is shown here. And then we make it a little bit like 0.5 mm, slightly larger in both dimensions. So it's kind of press fit nicely. And then I just use headless screws and patient is happy. So really the lesson I learned here is be careful. A chronic lock dislocation, it can happen anteriorly and posteriorly, as we all have seen. And for me, I can't address the huge bone loss, be it glenoid or in this case, humeral head, with pure soft tissues, and I end up using bone. Yeah. So those are the learning points from this case that I had.
Thank you.
So,
thank you.
Back to Bhupesh.
Thank you. Thank you.
I did the same procedure almost 6 months before one case with same humeral loss. I used the allograft and used the same technique. So,
Dr. Denny, why did you do a labral repair? Because we understand that the head had a defect and you put it back in and recreated it. But definitely this patient would have also had a labral tear.
Yeah.
So now that we were in, was it also worth it to go and...
Yeah, I did a labral repair as well. So the key thing is to fill up the posterior Hill sacks, and then I just did a labral repair since I was there, as you said. It's all opened up.
What was the approach, Denny?
It's just, I did a standard anterior approach, deltopectoral. Yeah. Because then to reach the posterior Hill sacks is a bit of a challenge, but if you externally rotate, that's why you saw my pictures. I couldn't see it really in on. You know, it's sort of like that. But it's good enough to fill up the graph.
Thank you, sir. Dr. K.N.Subramanian, sir, would you like to show the video or should we come back?
Go ahead. I will just show you in a minute. Okay. Go for another question and we'll come back to you. Okay.
Yeah. Perfect, sir. Perfect. So I will quickly go to the next question. So another question from one of our friends. Does the bone need to bleed after the labrum is freed for repair? How much of rasping is enough? It gets blurry once I do this. How do I manage this? When the labrum is repaired, apparently it becomes blurry. So how should he deal with that? Professor Arumugam, can you take the question?
Yeah. See, now after the establishment of the portals for the beginners, most important step is the preparation of the glenoid. Most important thing is to release. Now also there was a previous question, if labrum is healing, what should I do? See, there's no question of labrum healing. You have to see which position is healing. If it is healing below the on the neck, it's the Arpsa lesion. So in that case, you have to release it. So you don't need to have bone bleeding. You rasp it so that the fibrous tissues are not there. But very important is you have to release the labrum up to you see the subscapularis. That's where you will also see bleeding, but this bleeding you have to look for it. Unless you release it, you won't be able to do a south to north shift. So these are the key steps in that. And to answer in short, I don't have to bone bleeding, but the release of the labrum and the capsule up you see the subscapularis is important.
Thank you, sir. Thank you, sir. So we'll quickly go to the next question on preparation. Dr. Palanivel Rajan, sir, question for you. What to do if there is no labral tissue at all, or very fragile ligamentous labral complex? What do you do if there is no healthy tissue for repair?
No, in this case, once you dissect, most of the time you get some kind of capsular and labrocapsular tissue, which you can mobilize and you can fix it with the labrum. But you should always have in mind that this may not be adequate in high-level sportsmen. In those patients, if you have an opportunity, you can proceed with a Lathaje procedure, or you can just tell the patient that if he develops another instability, he may have to undergo a Lathaje procedure.
Thank you, sir. Very crisply answered. Dr. Ram Chidambaram, your thoughts on this scenario?
Agree totally.
Okay. Dr. Subair Khan? Dr. Subair Khan?
Sorry, I was breaking.
Only comment I want to make on that preparation of bony pate for the labral repair. It's enough, as Dr. Arumugam suggested, to just prepare a bony rough area. Rasp is enough. Do not use the burr to take off any bone, because many of our young dislocators or many time dislocators, the bone would be soft. So if they use the burr to take it, it might damage more. The purchase for the anchor would not be good.
Actually, once we elevate the labrum,
yes,
even if the tissue is less, we can even include the capsule. We can take a double bite over the capsule, and we can focus on the IGHL mostly. So most of the time, even with the minimal labral tissue, we should be able to bring back the IGHL to the position. So in that case, like most of the time, we need to elevate the tissue well. We still 90% of the time we will be able to get some tissues on it.
Thank you. Dr. Will, what is your preferred instrument for labral liberation?
Bhupesh, I use a rasp liberator,
okay,
and it's a dance between myself and my assistant, whereby it's a gentle. I tap with a mallet on the back of the liberator to begin it, and then it's a gentle to and fro motion. It's not an aggressive motion, because, and I'm sure the faculty will all agree, you know, you if you're aggressive, you rip through transversely, and then you've got nothing to repair, and that becomes a disaster. So I think it's just a gentle to and fro with a tap, 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 and work your way down.
Perfect. So, Dr. Sundararajan, next question to you. The last question of preparation here. How much will you release in terms of clock? Will you stop at 5:30, go to 6, go to 6:30? Because as we all know, you use your posterior labrum to pick up a bite from there. So how much, what is your end point of liberation in terms of clock?
Yeah, that is most of the time I go up to that 6:30, 7 o'clock position, because the extension of the labral tear itself will goes up to the 6 o'clock or 6.5. If you see carefully, whatever the labrum which was down in the neck, if you see the extension of the tear is very important. Sometimes you may not see that much extension. So in that case, I don't need to go up to 7 o'clock. As I said, Most of the time, it extends up to the 6 o'clock or 6:30 position. So I may need to go and elevate up to the 6:30, 7 o'clock position most of the time. But there are few occasions where I can go up to the only 6 o'clock, which is more than enough, because that labrum can be attached up to the 6 o'clock from the posterior side, like 8 o'clock, 7 o'clock, 6 o'clock, may be intact. So I no need to go and elevate the normal labrum. So I will see which is the normal labrum, which is the torn labrum. So I may go and extend maybe in another 1 centimeter, 2 centimeter further to mobilization purpose. Otherwise, I no need to do that most of the time, but I end up going up to 6:30.
Thank you, sir. For the benefit of our delegates, I have summed up what all the faculties have told. So it is safer to use 2 portals anteriorly, so you can view from your antro superior portal and you can elevate from your antro inferior portal. As Dr. Palanivel Rajan sir told us, most of the time from the posterior, it might look like there is no tissue, but when we look from anterior, sometimes very deeply, there can be some amount of capsulolabral tissue, which might be like an Alpsa lesion, and you can, with gentle teasing it off from the bone, not very aggressively, because we should not break that ring. We can try and get quite a decent amount of tissue. As Professor Arumugam told, it is important that you see the muscle of subscap, and that is an indication that we know that our release has been adequate. Of course, trial reduction also is quite important to know where to place your anchor and how to take your bite. So what looked like nothing, in this case, we have now received some amount of decent tissue to repair at the end of this release. Question to Dr. Sundararajan again. I think it's a favorite question. How far is the axillary nerve, and what is the problem when taking a bite with your inferior most?
As I said, no, if you go through your intro inferior portal and if you try to take a bite, sometimes what happens, you may struggle to view, or sometimes your lasso, because you're taking the bites and bring up will be always very tough. So sometimes what try to do, then you try to go more deep, then there is a problem. If you go more than 1 centimeter deep at the 6 o'clock position or 6:30 position, where they have a problem of encountering with the axillary nerve injury. So that way you have to be very careful. That's why maybe what I use in the posterolateral portal is very useful for me, so that I can go through the posterolateral portal, so that you don't need to use the deep bite. So you can take a gentle bite through the posterolateral portal and you can bring it up. So you have to be very careful that you are not taking a deep bite at the 6 o'clock position, where you are going to take your first bite and bring it advancement. So that bite has to be very careful.
Okay. Dr. Will, are you scared of it? The axillary nerve?
Bhupesh, yes, I am very scared of the axillary nerve. And I think we've got to be very respectful of it. There's a nice paper by Hamada in Arthroscopy, February of 2020. And they looked at 2,000 of their arthroscopies retrospectively, and 4 of the cases ended up with an axillary nerve palsy. And they noted that going back at the pre-op MRIs, that the axillary nerve on those was as close as 3.2 millimeters to the inferior margin of the glenoid. So yes, to answer your question, I'm very respectful of the axillary nerve.
Okay. So any tips on how to avoid it rather than taking a smaller bite?
I'm not pro utilizing scorpion type passes from intra-articular, whereby you're taking a blind bite of labrum and capsule. I err rather utilizing pro-grade passes such as the AcuPass or an instrument similar to that, to lasso. That way you can take a superficial bite of capsule and include labrum without having to, as you know, as our previous faculty said, taking deep bites. Change your portal rather than accepting having to take a deep bite.
Thank you, Dr. Will. Our next question is as follows. How to get a good bite for your inferior anchor? How to do a good shift? And should I always do an interval closure? Dr. Will, I'll be happy if you can share your slide to answer these questions quickly.
Can you see the slide there?
We could.
Yes.
Okay,
Prakash,
so
we can see very well.
so to take a bite, I would like to get specifically in a patient with some evidence of ligamentous laxity or a previous multiple dislocations. You do want as much capsule. You want at least 1 centimeter of capsule, and you want the entire labrum. And once you've done the release, to see that floating up. So just some tips from my side, and I'm happy to debate this point. My first suture, that I put in is the superior suture that I then is as a luggage tag, and then I park that out of a separate portal or the superior portal, so that what I can do is use it as a traction suture. I then will proceed to my inferior most suture, and then start with my south to north shift. I think if you start with the inferior most and place it and anchor it, you cannot continue your south to north shift as effectively as if you place a traction suture as far superior as you can. Anything more on that, Bhupesh? Are you happy with that? So that would be my sort of closure on that.
Bhupesh, unmute.
Yeah. Thank you, Dr. Will. So our next question is how to tackle lax anterior capsule. I think this is something very important. Dr. Denny, can you show us your slides on how you address capsule?
Can you see the slides? Yeah, so what I want to share with this short presentation is my approach to a lax anterior capsule and how I take it in a layered anatomical way. So this is a case, classic young patient with a dislocation after a fall, then recurrence, and he's a karate guy. So there's laxity, there's capsular laxity. So these are the scans. There is a Bankart, there's a Hill-Sachs, a small one, type 5 slab. So it goes up all the way in a very loose patulous capsule. Not particularly good for a karate martial arts guy. So then the question is, what should we do? I think we can all agree option 1 is out. We do need to do something for a guy who's active in martial art. I wouldn't do a remplissage. Question is a labral repair enough? Or do we need to do a capsular shift? And how do we approach that? So what I want to share with my point is I tend to do capsular shifts because over the years, what I found is that our Asian patients has that little bit of capsular laxity. It's as if there's an embry background to it all. And then they have a torn labrum over and above that. So I tend to, over the years, pay attention to the layers of the capsule, the IGHL and then the capsule to tighten it layer by layer. And this is how I do it. I'll show you. So I see it as a stepwise way. My first bite is a labrum. Second bite, so pure labral bite gives me a simple repair. My second bite from the same suture, from the other limb of the suture, bites the labrum and the IGHL. And that second bite gives me a mattress stitch. Because most anchors have 2 sutures, so the third suture, I do the same with a bit more capsule. And that bite is perpendicular to the mattress. creating a Mason-Allen-like. And so over the years, I've learned to take it layer by layer. And this is what it looks like. So this is a camera from the anterior superior portal, and you can see it all the way down. So like what was discussed earlier, doesn't seem to be a tissue, but if you really liberate it, you will be able to get something. And if you pull it up, you can create a labral-like tissue. Look at that. See, slowly you tease it off, it'll come out. Then my lowermost anchor, any which anchor you use, this will be my first bite. Pure labrum bite, as low as possible. I spoke about bleeding. Yes, I liberated. There's always some bleeding. That's good for healing. My second bite is then above it. It's both labrum and anterior IGHL. I then create a mattress stitch this way. So the way I deal with lax capsule, I bite it layer by layer, incorporating into my repair slowly. Yeah. So then my third bite is both labrum, IGHL, a little bit of capsule, but it's in between the mattress. Yep. So that's a classic Mason-Allen-like. And I then slowly build up to repair. Then see how I bring the striped sutures behind the mattress. Yeah? You don't cross the mattress stitch, behind it. Then as you tie it progressively, the knots are all outside and very nice interior wall build up. And if you want, you can even close the capsule with a fourth bite, but that's really optional. So what you need to see at the end point is a nice shift. Not only the labrum is incorporated, but entire capsule and MGHL is then brought in. You create an entire wall. So even if the labrum looks deficient, by doing this, you can build up a wall. And that's how I've learned to overcome lax anterior capsule. So it's layered by low recurrence rate. That's what we had in our latest results. So in summary, what I've learned is to appreciate the layers of labrum, IGHL, and capsule, and bite them piecemeal in order to create a nice wall. So Bhupesh, thank you.
Thank you, sir. Perfect. That was very nice indeed. Thank you. So thanks for showing that. Because we are overshooting, I'll quickly go through the next few questions. The next question is, do you need an accessory portal for inferior anchor placement or for taking the bite? I would like Dr. Karthik Selvaraj to answer this question. Do you make another portal other than your antro superior and antro inferior portal for the 530 anchor?
Yeah, I sometimes use a trans-subscap portal. So if you in a big shoulder, if you can't get your lowermost anchor as low as you want, then you can actually go in with a. So what I use is a 2 mm K wire. So use a 2 mm K wire. The landmark is slightly lateral and inferior to your antro-inferior portal. So you just go with your K wire. You will be actually going just below the rolled upper margin of the subscap through the subscap. And once you go in with your K wire, you can go straight where you want to put your anchor. And when you go there, after that, you can actually railroad your sheath for the anchor, which is the normal anchor sheath. You can just railroad it onto that K wire very carefully. Your K wire should not overshoot and cause any cartilage damage. So once you do that, you can actually put your, because when you use this portal, there is a real risk of injuring the axillary nerve. So if you can't really get low with your through the antro-inferior portal, you can use the trans-subscap portal. For taking bites, there is no problem. Usually for putting the anchor is, the advantage of using this is the angle is perfect. When you put the anchor, you don't go in this direction. You actually come tangentially right on the face of the glenoid where you want your anchor to.
Thank you, Dr. Karthik. Dr. Sundararajan sir, do you use another portal for your anchor?
I have not used accessory portal, which is not required for my Bankart report, for only for the soft tissue repair. It is not, I mean, I have not used it. Sometimes you may need to use it for your bony Bankarts. At the same time, we can remember that there are commercially available flexible cannulas are available nowadays. So you can go through even same antero-inferior portal can be used if you have the backup of that antero-inferior cannulas, like a few companies has got the flexible ones. So you have the backup. Is like if you find like obese or difficult patients, you can still use that.
Dr. Ram Chidambaram, do you use accessory portal?
I was about to tell what Sundar was suggesting. The accessory portal, we use it for when you want to fix the glenoid fracture. The safer version is to use a curved guide and then a flexible rebar. And you could take even a flexible peak anchor or a all suture anchor at 5 o'clock position. It's possible to do, but you had to make sure that angle is pointing towards the glenoid.
Thank you, sir. Thank you very much. Now that Dr. K.N.S. is back with us, sir, what suture passing device do you use? And can you show us a quick video on how you use your suture passing device?
So, for the inferior most bite is the only one which is a different one. Okay. For doing anterior capsule, you don't have to use any, you can use a conventional devices like 30-degree lasso, those things that you can use, or a Smith & Nephew, any of these can be helpful. I just show you for doing the inferior bite, you can access it from the, can I share the screen?
Yes, sir, please.
Okay. Are you able to see it?
Yes, sir.
So, our aim is to get our south to north shift, isn't it? That's what you want to get. So in order to get that, what you have to do is you have to take at least 1 centimeter of tissue right from the inferior capsule.
Sorry, voice is not there. Subra talking. We can't hear you.
Can't hear me?
Yeah, we can. There's some connectivity problem.
Now keep watching this video. I'm using a device, anti-grade suture passer. And this suture passer is actually, width of the suture passer jaw is about 1.5 to 1.7 centimeters, which means if you are going far deep, you can actually catch about 1.5 centimeters of tissue over there. This is especially useful in situations where your labral disease is very bad and capsule is the only thing that you are going to see, like capsuloplasty. And also when you are using these kind of anchors, you are actually trying to tighten the capsule anteriorly, as well as you are trying to bring the tissue from south to north or inferior to superior. By this, you can actually make your tightening of capsule. This is one way of doing your inferior capsular stage. Another way of doing is you can try it from the posterior portal. If you go from posterior portal, you can take a lasso kind of device and take a bite from about 6 o'clock position. My idea is not to put anchor in around 6 o'clock normally. If you put anchor in 6 o'clock, then you cannot get the real tightening effect. So put your anchor around 5 or 5:30 only, not beyond that. Then you can take your bite at 6 o'clock. If you do like that, then you can actually try to get the tension of the inferior capsule much more better. So in the open surgery, we should do the inferior capsular shift. That kind of capsular shift can be achieved only if you are putting your anchor little proximal than what you should. So you should put an anchor at 4 o'clock, then you take a bite at 5 o'clock. So you try to do it from inferior to superior gradually, then you can actually end up with a nice tightening of the capsular diaphragm structure from inferior to superior.
Thank you, sir. Any other faculties got other views? Anybody else? Because Dr. Will, you already said you will be using Accupass-like device. Anybody using any other types of devices for your antilabral suture passing? Inferior one.
If you want, I can show the posterolateral.
Yes, sir. It will be fantastic, sir. Can you share your screen to show that, sir?
Can you see my screen?
Yes, sir.
So you can see this is how you make your posterolateral portal. As you can see, already there's cannula in the posterior side. That is a regular posterior portal. So this is your entry for your posterolateral portal. You cannot make a bite through your posterior portal. You need a little higher view. I mean, you have to come through the from above. So you have to make the separate posterolateral portal. This is how you make your posterolateral portal here. Then you insert your, here you don't need to use even 45 degree. This is 25 degree lasso is more than sufficient. So you can come around against 7 o'clock position. You can see I liberated up to 7 o'clock position over there. So here you only take a deep bite. So if you're from 7 o'clock position, you can take the first bite through the posterolateral portal. So you can easily elevate that labrum. You can bring the bite over like this. You see that?
Nice, sir. Very nice, sir.
Okay. Thank you.
Thank you, sir. Dr. Prakash, can you quickly show us a regular accupass on how a bite is taken through that?
I'm sharing my screen, man.
Prakash looks very tensed face.
I love it.
Time is almost getting over. Only 2
Yes, sir. Another 15 minutes, we'll wrap it up, sir. Quickly. Prakash, by the time you...
Sir, I'll just make it ready, sir, by the time we can take it.
Yeah, I have a question quickly to the other faculty by the time you get that ready. Do you believe in the concept of engaging hill sacks? Dr. Ram Chidambaram?
Can you hear me?
Hello, yes, sir.
See, all
hill sacks were engaging.
They have to engage to dislocate. But what we decide is the width of the hill sac lesion that is measured by the on tracking comparing to glenoid width, because it's a combination. If there is also a glenoid anterior loss to some extent, it will contribute to the instability from the hill sac defect. So that makes more valid point than simply calling it engaging or non-engaging. I think you are showing the slides.
Perfect, sir. Yes.
So for the beginners, there is the regular accupass is a time-tested suture passing device. The advantage is it is easy to use. The large shaft allows for better maneuverability, and this is best for plication and approximation of the labrum. So right now, what you see is your traditional accupass. You take a nice bite on the antero-inferior aspect, and it becomes easier when you come on the 3 o'clock and 12 to 1 o'clock position. So if always it is better that you liberate the labrum. If something goes wrong, you're not able to properly take an adequate bite, it is because you're not liberated the labrum properly. If you have liberated the labrum properly and the labrum is coming above the glenoid, then taking a bite is not a problem at all. So if suppose there is a problem, there is a bailout option. You can use a traction grasper like this. You can pull the labrum as superior as possible. So you have a little edge for maneuverability of the accupass, and then the bite is easily taken from the anterior and inferior aspect of the labrum. So this is how we do it. These are on the right side corner, you see different bends of accupass, 45 degree or 70 degree. And most probably, I think 45 degrees should suffice. So that is how you do using a traction pass.
Thank you. Thank you, Prakash. Thank you. Very nicely shown. Thank you, Prakash. Quickly to Professor Arumugam. Sir, glenoid bone loss, how much is the cutoff for you to do something like a latter J? So what is critical bone loss in the glenoid, sir?
Yeah, it's a very important question, Bhupesh. Before you plan your management, if there is a glenoid bone loss about 25%, then it is not suitable for soft tissue procedure or think of the latter J. So for me, it's 25%.
25%. Thank you, sir. Dr. Will, what is your cutoff for planning something bony rather than soft tissue repair in the glenoid?
Bhupesh, my absolute number is about 14 to 15%. In the collision or contact athletes, so I see a lot of rugby players. We know that the Bankart repair will fail. So even in the event that there's no bone loss in a rugby player, I will almost certainly offer them a primary Laudage as my procedure of choice.
Okay. So for an many literature says 25, but we do accept that in high demand athletes you can go as low as 18% as the critical size size of glenoid bone loss. I quickly want to go through the glenoid tract because many of the delegates had asked about the concept of glenoid tract. It is the tract that is made by the humeral head itself on the glenoid, and it is studied to be 83% in live subjects when the arm goes into maximum external rotation and abduction. So that is the glenoid, and if the heel sac is within the glenoid tract, it is an on-track heel sac, and if it is further medial to it, it is an off-track heel sac lesion. This is the study. You first, with your circle concept, find the diameter of the glenoid base. You can also quickly do a screening of the opposite in uninvolved shoulder to know the actual size of the glenoid, which is now 100%. And you will take 83% of that. And that is the glenoid tract for this glenoid. If, like in this case, there is a bone loss, you will minus that bone loss from the existing 83%, which is that red arrow. So when there is no glenoid bone loss, 83% of the glenoid width will be your glenoid tract. And if there is a bone loss, the red arrow 83 minus the bone loss will be your glenoid tract. And as we said, if the heel sacs is inside the tract, it is on track. But if the heel sacs is outside the tract, it is considered to be an off track. This is by Bankart and Richard, and this is a landmark article. And based on that, you have 4 options of treatment. If it is on track without glenoid defect or less than 25 or 20%, you do an arthroscopic Bankart repair. If it is an off track, you will do an arthroscopic Bankart repair with remplissage. And as Prof.Arumugam had said, but in high demand athletes, there is a small role for latter J, as Dr. Will said now. But if there is a glenoid defect more than the critical size, you will directly do a latter J. Sometimes, if it is still off track, theoretically at least, you will have to add a remplissage to that. So now quickly, I will bring Dr. Will inside. Do you have an decent way to estimate bone loss? You do something nice in your department. Can you show us about that?
Bhupesh, I'll show you there. I use a 3-dimensional printer, and yeah, so I've been 3D printing my instabilities. I'll just show you a screenshot of that. So that's it. That's it over there. Let's just try and get that a little bit bigger. There it is over there. So this is a case of from about 200 kilometers north of me at a hospital. Patient had a dislocation, ended up with a Bristow procedure. So you can see the 3-dimensional CT on the left-hand side, and then that are printed in the rooms. And I think it's becoming more and more achievable to have 3D printers in our rooms. Gives us a very good idea to plan surgery going forward. And it seems to be quite a big trend. I got back from a meeting in New Orleans end of last year, and the guys there tend to be using 3D printers more and more. And that's what sort of stimulated me to get this. So yeah, quite exciting, and I'm really enjoying it.
Nice. That was very nice. Now, very quickly, before I go to the next topic, we all know that the concept of off-track and on-track is based on CT scan, and we really don't know how to quantify the capsulolabral content which we have been discussing so far. Karthik Selvaraj, can you quickly show us your scoring scale that you have come up with, and how do you score the treatment and plan the treatment for instability cases?
Can you hear me? Yeah, can you hear me?
Yeah. As Karthik is sharing, a quick question to Dr. Denny Lie. We have a question. Will you remove some amount of cartilage from the anterior rim of glenoid before placing your anchors to aid in healing?
No, I try not to, Bhupesh. I really don't want to compromise the articulating surface. If you want good healing, really it's that anterior portion of the glenoid that you need to sort of strip away and decorticate the soft tissue off. That's the healing thing. So I don't need to create on-table sort of healing. If I really want to do a good healing, I do a dual roll labral repair, but it's really on the anterior part, right to the edge of the table. Yeah.
Perfect. Thank you. Karthik, can you come up with the screen? Yeah. Karthik, can you quickly run us through your algorithm?
This is the algorithm we use. So this is any patient with recurrent instability, along with an MRI, gets a 3D CT. So physical examination, Baton score. So once the 3D CT is done, you would know whether the patient has a bony Bankart or a glenoid bone defect, and an on-track and off-track, as nicely shown by Bhupesh. So a patient's glenoid index, if it is we follow the cutoff of 20% here. So any patient who has less than 20% glenoid index, we do a Latarjet straight away. And the bone loss more than 20%, they get Latarjet. In addition to that, if any patient is a contact athlete or a manual laborer, they do get they also get a Latarjet done. Now, if the patient has got any other high risk factors like poor labral quality, like we kept on discussing about bad labrum. So intraoperatively, if we find that the labrum is bad, so all the contact athletes and manual laborers have already gone into this Latarjet group. So any patient who is not a high demand person, but who has poor labral quality intraoperatively, who is hyperlax and who's got an off-track heel sac, which is calculated just like how Bhupesh told us. If these factors are present, then this patient gets a Bankart with Rumplissage. So the Rumplissage here for a poor labral quality acts to me like an insurance, just a backup plan, which you can do immediately, then and there, rather than converting the patient from lateral to beach chair to do a Latarjet and all that. And if the patient is off-track heel sac, obviously you have to do a Rumplissage. And if the patient is hyperlax, just to tighten him at the back, just like how Dr. Sundar takes a bite in the posterior labrum. We actually take the bite on the posterior capsule, but we take it on the humeral side, not on the glenoid side, by doing a Rumplissage. So the Rumplissage is basically posterior capsulodesis. None of these factors are present in a sedentary, middle-aged, office-going male, then he gets an arthroscopic Bankart. So this is quickly the summary of our algorithm, Bhupesh.
Perfect. Thank you. Thank you. Thank you, Karthik. Very nicely shown. Next question, Dr. Ram Chidambaram. Can you come in, sir?
Yes, please.
Yeah. So there's a question. After placing 3 anchors anteriorly and after achieving a good bumper effect, if there is a gap between 12 and 3 o'clock, can we ignore it or should we place a 4th anchor?
I think the key repair is from 3 o'clock to 6 o'clock. That if you get the IGHL tension and the bumper effect in that area, it acts as a hammock to support the humeral head. Absolutely, that 12 to 3 o'clock, that anterosuperior labrum doesn't contribute much to stability. But the exception to repair that is an extended slab lesion. There is a slab lesion under labral tear. You want to get the entire labral ring intact by inserting additional anchors.
Okay. Can you talk about some normal anatomical variations between 12 and 1 o'clock, which might be missed as a lesion for the beginners?
Sometimes you have a B4 complex, but that's the incidence is very small, it's under 5%. And if you, in case you encounter and the patient is a frequent dislocator, all you need to do to address the antero-inferior labrum and IGHL tension.
Perfect. So if you have a cord-like MGHL and a sublabral foramen, which constitutes the Buford complex, it is wise not to go and put an anchor there because it's a normal anatomical variant. Quickly coming to anchors, first question to Professor Arumugam. Sir, what is your choice of anchor?
I now use always the all suture anchors for my labral repair because it's very low profile. And so I started with metal and all bioabsorbable. Now, all suture anchor is my choice for labral repair.
Thank you, sir. Dr. K.N.S., where do you place the anchor? On the face, junction of face and medial?
You know, I'll show you a slide about that, yeah?
Yes, sir.
Let's just start sharing the screen now. Huh?
Yes, sir. Yes, sir, please. So
this is, can you see the slide now?
yes, sir, yes.
So this is the typical place where you want to put it. So it's not on the edge here. It's not over onto the articular surface also. It has to be on the about, you have to leave about 1 millimeter of the bone bridge or 1 or 2 mm. So normally the diameter of your drill guide is ranges from 2 to 3 mm. You have to leave 1 mm bone bridge. So it should be within 4 mm of your glenoid on the face. Don't put on the medial border. If you put on the medial border, you may not get that bumper effect at all. So if you just see this one, after doing this anchor drill, I got small bridge over here. That's all. That bony bridge is over there. If you go even more medial to that, then you will kind of skew off. So it has to be on the edge, on the face of the glenoid or the place so that you can have some bony bridge also and can get a bumper effect.
Perfect. Thank you, sir. Dr. Subair Khan, next question is yours. Now, how many anchors do you consider as too many? How many do you regularly make? How many anchors do you regularly use?
Most of the time I use biocomposite, anchors, sutureless, knotless anchors most of the time. And depends on the lesion I use. So minimum 2, maximum is 3 anchors is what I use. I've not used more than 3 anchors in most of my cases.
Thank you, sir. The next question, Dr. Palanivel Rajan, sir, do you use curved anchors?
No, I don't use curved anchors. Nowadays I have switched to all suture anchors. Okay, so I don't think.
So all suture anchors gives us more real estate because it is very small.
Yeah, of course. Very small drill. You make use of curved cannulas and flexible drill bits, drill guides. So that's more comfortable now.
Yes, sir. Sir, do you use the knotless repair that some videos we saw by a few faculty before? Dr. Subair Khan was talking about it. Do you use the knotless anchor, sir?
No, I have tried knotless anchors, but I would prefer to use knotted anchors because I'm very comfortable with that, and I'm able to adjust the tension of the labrum. So I think in my hands, I think even the knotted anchors are as good as knotless anchors. Knotless, sometimes you cannot tighten much as you want. So knotted, I think it gives me a better, more comfortable for me.
Nice. Thank you, sir. Dr. Sundararajan, sir, do you use all suture anchors? Do you think it is better than PEEK and biocomposite in today's practice? Your opinion on that? Sundar, sir?
Sorry, if you see the, literatures, the failure of a mechanical failure for the loads, I think almost is equal, even all suture anchor holds good. So I think idea of using all suture anchors definitely helps even the revision procedures, so that your revision procedure to put an anchor in the same position close to the 5 o'clock or 5:30 will be easier if you use the all suture anchor. So usually I do all suture anchors in my inferior anchor at 5 o'clock with the double loaded, so that I can have a control of shifting and taking bites, and with IGHL, so that I make sure that my inferior capsule is shifted superiorly, and the tension was created by careful controlling over the knots. Of course, the remaining switches at 4 o'clock or 3 o'clock, most of the time I use the knotless. So just I want to roll back the labrum to go back into the position. So in that position, I use knotless anchors.
Thank you, sir. Thank you. So we have already seen this, so I'll quickly skip this video. So coming to knots, Dr. Denny, you showed us a beautiful version of your simple and mattress knots. Dr. Ram Chidambaram, can you tell us what is your preferred knotting, simple or mattress?
Mostly I use simple sutures only because that gives you the direct approximation to create the bumper effect. But if the labral quality is good in a fresh case scenario, you could use the mattress.
Okay.
The
Thank you.
combination of both.
Professor Arumugam, your thoughts on this? Simple or?
Yeah, my preferred thing is simple knots. I rarely use mattress suturing for the labral repair.
Thank you, sir. So I'll quickly, now we have a lot of questions on knots, but I will let Karthik show his slides on that. Karthik, can you run through your slides on knots and the various types and the easy ones? Karthik?
Yeah,
Dr.
can
Karthik Selvaraj, can you run your slides on knots?
Yeah.
So very quickly before that, on placements of knots, Dr. Will, do you believe in the concept that the knots should fall on the soft tissue sides? Is it okay if it falls on the bone side? Do you think it's going to cause arthritis and problem later on? What's your call on that?
Bhupesh, I do believe on keeping the post on the capsular side. I don't think you're going to end up with arthritis, and I haven't seen much in terms of my practice or the literature. What I have seen, however, is those patients that have knots on the labral side do end up with a knot synovitis, and I've had to take one or two patients back to remove the knots with the synovitis. So I think it can be a pain generator, yes.
Thank you. Karthik, please carry on.
See, a couple of things. See, as beginners, we are always apprehensive about knots because you do all the hard work. You actually put your anchor, do your liberation, put your anchor, take the bite, and then the final climax is your knotting. And then when you actually lock your knot, when you do use a locking knot and you lock your knot and your loop is already loose, you've locked it prematurely, then you know all the fun in surgery goes, and you actually wasted an anchor. So it's very, very important to practice knotting, you know, before you venture into this. So a couple of things. One is past pointing. So you need to be, you need to know how to do this. Past pointing is something like how we do a handheld knot. You tie the knot, you actually pull both ends away from each other. So you do that with your knot pusher inside. That is something which you need to practice. And you need to do these, know these two things, which is the loop security and knot security. So your loop has to be secure and your knot has to be perfectly tight. And a couple of ways to do this. I'm just going to show the knot which I use. This is the Western knot. It's a very, one of the best sort of sliding locking knots. So it's a small video as to how to do this. So you got the black, that's post, and the white part of the shoelace is the sliding limb. So the post and the sliding limb. So you got the post is always short. You keep the post short because when you actually pull on the post, the knot slides in, and then you have equal limbs of both the sutures once the knot is sitting inside. So that's the way you take the loop inside, and then comes all the way around and then passes through the first loop. So this is a very simple secure knot which I do. And then after you do this locking knot, you push the knot inside, place it onto the labrum, and then you dress the knot. You actually have to dress it, make sure it sits very nicely, comfortably. Your loop is secure. First secure your loop nicely, and then actually pull your sliding limb so that the knot is locked. So that's something. And then after that, you have to secure it with half hitches. So these are reverse half hitches and alternating posts. It's called RHAP. So you got one overhand, one underhand, and then switch the post and then put another hand. There is a simple way you can switch the post without actually changing your knot pusher. So if you really, can you see the video?
Yes,
can you see
go ahead.
So that's the knot coming in. You know, always the inferior most is the problematic. So once the knot is actually sitting on to the place where you want to, you make sure you dress the knot nicely, make your loop very secure first, and then you lock. So before that, if you lock, then the whole construct becomes totally loose. That's it, Bhupesh. Do you want me to show anything else?
Thank you, Karthik. That was fantastic. It was very nicely shown. Now, quickly I would ask Dr. Denny to come in. Lot of questions on bony Bankart. Can you just run us through on how do you tackle bony Bankart, Dr. Denny?
Okay, so we'll show you presentation on bony Bankart. Yeah. Can you hang on? I think there's something wrong with sharing. Let me try again. Bony Bankart. Let me come back to you, Bhupesh.
Can you just share your desktop? It is not, we are unable to share it on the play mode. Just share your desktop screen. It just comes.
Yeah, because what I've been trying to do, share the desktop. Okay. Can you see it now?
Yes.
Yeah.
Because bony Bankart, I can't seem to play it at the moment.
Don't put the play mode. You just
now you can go and choose the bony Bankart presentation.
Tell you what, let's come out first.
Okay.
Let's come out first. Let me run through the PowerPoint again, then I'll come back to it.
Oh, yes. Meanwhile, I will pull in Dr. Will. Now, what if your Bankart fails? Do you have an algorithm for failed Bankart? Can you run through that first quickly?
I'll share my desktop there. So I think the faculty have dealt with this extensively, and Bhupesh, I'm happy to email this to you if you want to share it with the delegates. It really just is a summary of what we've been talking about: understanding the anatomy, performing a thorough history and physical examination, getting the correct imaging with respect to CT, MR scan, understanding why it failed. Was it recurrent trauma? Were there patient factors that were specific? Have we missed pathology, like Denny pointed out? We've, the rest of brilliant talks by the faculty in terms of the technical factors about your knots, where your anchors go. And then your management will then determine on so non-operative, very seldom, those would really be your elderly patients, dealing with your revision, Bankart, capsular plication reconstruction, dealing with the Hill sacks like we saw in that chronic locked anterior dislocation, and then obviously moving on to bone augmentation with respect to either Latarjet or iliac crest. Okay.
Bhupesh, do you want me to share now?
Please go ahead, sir. Thank you, Dr. Will, for that.
So this is a case of a bony Bankart, and I want to share what we can do with it. So case example is little 31-year-old guy, active sports person, multiple dislocations, but good ROM, otherwise is good. MRI shows bony Bankart about 15-20%, sort of the gray zone area. These are the MRI scans. You can see that bony Bankart, it's pretty fresh. And on the video, you can see that piece is still viable. It's not resolved yet. And you kind of want to preserve it. So then the question is what to do. At about 15% bone loss, is it acceptable? Do we just do soft tissue label repair? He's not an extreme active sports person. He's a dragon boat rower. So it's not a collision sports. Or do we want to repair this bone fragment, incorporating into it? And if so, how do we do it? Do we fix sutures through the fragment or around it? These are ways that you can do. Or should we just ignore it and just do a glenoid reconstruction? So these are the many options, and we can discuss this. But this is what I did. For me, 15 to 30%, I try to repair it and incorporate that bony fragment into the repair. Anything bigger, because most of our patients are not the collision type, only if it's much bigger than 30%, then I do either Latarjet or glenoid recon. So for me, I start off with putting a medialized anchor, what I call the AIM anchor. Then I pierce through the fragment, and I try to bring all the sutures through that fragment. So I fix that fragment with all the sutures. Yep. Then I bite 2 sutures above the fragment and 2 sutures below. So I effectively entomb my bony fragment in a soft tissue envelope over it. Then I place the sutures onto the rim anchors, which are knotless. I close the capsule in between them, and I place the superior knotless anchor. And in effect, I then have an entire coverage, and I know for certain that bone fragment is inside. So for me, if there's a bone fragment, try to preserve it. And this is how I do it. I try to incorporate it into my soft tissue repair. I pierce the fragment rather than going around it. So MRI 6 months, nice, good healing. So what have I learned with bony Bankarts? These are acute injuries, must be dealt with in a timely manner, early enough before resorption happens. So I try to incorporate them into the repair, around about 10-20% of the bone loss. I entomb the fragment by piercing it, incorporating into my soft tissue repairs. And that's how I deal with my bony Bankarts. Bhupesh?
Perfect, Dr. Denny. Thank you so much. We will stop taking questions now because we are coming to the end of the program. I would request Dr. Will to come in and present 2 interesting cases, after which Dr. Denny, you, if there's time, will present your interesting case, and with that we will end the meeting. Dr. Will, can you come in and present the interesting cases that you have for us?
Okay, you got me there? You got the screen there? Okay. So this is this is early on in my career, about 6-7 years ago. I had a rugby player who presented with an anterior shoulder dislocation, Bankart tear confirmed on MRI scan. He wasn't a professional rugby player and his intention was not to really continue. I performed a Bankart repair utilizing 3 knotless anchors. He settled okay, but after about 2 months developed pain. And I then x-rayed him, and I noted on the x-ray this metal artifact I was unsure of its origin. So I'm just going to move this out of the way, so apologies. So I don't know why the thing's not moving. Okay, so the CT scan confirmed that it was within the joint and was obviously rubbing on the humeral head. Discussed, I was uncertain of its origin. Spoke to the patient and said, we've got to go back in and take it out. So you can then see my arthroscopic images there. There's that metal artifact with the corresponding kissing lesion on the humeral head where it had worn some cartilage off. So you can see it quite clearly there. Took it out. What was it? And what it is, and it's just a note to the younger guys, is when you are putting in knotless anchors, they've got a mechanism with a screwdriver that will close a small peak screw onto your sutures within the anchor. If you change that angle between the anchor and the shaft of the screwdriver, you risk shearing off the screwdriver, and that's what had occurred in this patient. So there's the anchor there. So that was just an interesting case. You only do that once in your career, and you don't do that ever again. So just quite interesting. Second one, this is a case that's ongoing at the moment, and I'd love to get the faculty, including Denny and the international or the Indian faculty, please guys, your opinions. This is a patient at the time, 22 years old in 2010, had traumatic dislocation playing rugby, first dislocation, no ligamentous laxity. I can see a bone fragment. So this was done at a hospital about 80 kilometers from where my hospital is. From what I gather, it looked like they did a bone Bankart repair, an open repair, and this was the x-rays at 3 months. So that was in 2011. These were the post-operative x-rays. I don't think there's anyone in the faculty or probably in the audience who would have accepted those as acceptable x-rays. You can see that the one screw is already making contact with the humeral head and then has left a defect. He then carried on, and I'm not sure why if he was lost to follow-up or he didn't go back to the surgeon, but he presented to myself about four months ago, complaining of pain and reduced range of motion. And one can clearly see that there's been extensive destruction of the head following an open Bankart repair with the screws now awry. I then performed a CT scan, and again, it just really shows you the magnitude of humeral head wear. At the time, I went in arthroscopically, noted that the humeral, that the rotator cuff was intact, and I removed the 2 screws arthroscopically. His range of motion, active external rotation to 40 degrees, abduction, external rotation to the back of his head, internal rotation to his buttocks. Pain score not particularly high, 3 out of 10, minimal night pain, and his aim at 32 years old is he would like to return to CrossFit and gymnasium type work. So, you know, that's where we're at. And I don't know if I have all the answers, and I'd value some thoughts and ideas. Bhupesh, you there? Do you want to give us? Is anyone? Who should we? Denny, would you give us an
Will,
idea?
can I ask? Yeah, Will, can I ask how much of the humeral head is degenerate or arthritic? It looks like interior 30%, 40%?
About, I was going to say about a third of it anteriorly degenerative, and the sort of posterior 2/3 is not bad.
And the glenoid itself, the interior part is somewhat eroded, but how many percent do you think? Sorry?
I reckon he's probably 20% of the anterior glenoid has been eroded.
Yeah. And I gather it's not a question of instability, right?
No. So it's arthritis and pain related, and obviously reduced range of motion as a result of that.
Yeah, if it bothers him too much, I tend to go with an allograft, an interior part of the humeral head. I'm trying to avoid a metallic hemiarthroplasty at 32 years old. And if it's glenoid is not a problem, I'll just deal with the humeral head first and make sure the soft tissue balancing is great. And that's it for the moment. Yeah.
Dr. Ram Chidambaram, your views on the case?
I agree with that. It's a challenging problem at 32-year-old because he's got stiffness, he's got pain, we're dealing with arthritis with a glenoid deficiency and humeral head deficiency. So I had to agree that glenoid has to be grafted.
Yes, please.
Humeral head allograft, or you could go for a stemless hemiarthroplasty. But then we have to consider revising that in the future.
Yeah, thank you, sir. Thanks for the views. So, Will, best of luck for the case. Huh? I think you're going to do it now. Huh?
Oh,
I'm going to have to invite you all to South Africa to come do it with me.
Yeah. I think we've come to the end of the meeting. I would quickly like to thank all the delegates who have sent in their questions. We received more than 35 questions in 48 hours. I'm naming few: Dr. Arvind from Salem, Dr. Deepak, Dr. Balasukumar, Dr. Santhosh, Dr. Sivakumar, Dr. Naveen, Dr. Rufus Raj, Dr. Ram, Dr. Balasubramaniam, Dr. Deepan, and quite a lot of other people. I am not able to bring in all the list, but thank you for all the questions which made the webinar go through smoothly. And over to our secretary, Dr. Subair Khan.
Subair, are you around?
You have to unmute yourself.
Muted.
Subair, unmute. Yeah.
Yeah. Wonderful gathering again by the TNAS, and I should thank first Dr. Bhupesh and Dr. Prakash for organizing this, because they have taken a much pain to do this good event again. And I'd like to thank Professor Denny Lie from Singapore and Dr. Will Haynes from South Africa for giving their wonderful opinion about the Bankart repair and their presentation and their complications too. So it was very interesting. And I'd like to thank Prof.Arumugam and Dr. K.N.Subramanian, Dr. Sundararajan, Ram Chidambaram, and Dr. Karthik. It was a good gathering. And of course, the best part is the delegates who have put up the good questions, and it was a good interactive sessions. Rather than being one side, it was more of a discussion forum. So it'll be useful, I hope, for all the delegates and the faculties also, in fact, to share their knowledges about the Bankart repair. So anyway, we'll definitely meet in future. I think the future is going to be with more of webinars, so that we can, as Professor Denny was saying, like it's going to be a future of meetings. So where people can come together very quickly and easily, and we can share our knowledge very easily for us. Anyway, take care, all of you, and stay safe.
Thank you.
Thank you.
Thank you very much.
Also like to thank Dr. Sandeep Biraris. He has helped us in setting up the meeting. Sandeep, thank you very much for helping us set up the meeting.
Thank
Sorry,
you.
Doctor, I missed you. Dr. Sandeep.
Thank you. Bye, Dr. Paul.
Thank you, everyone.
You will.
Denny, thank you. Will,
Thank you.
Ram, thank you. Sundar, thank you. Arumugam, thank you.
Bye, Denny.
Karthik, Prakash,
Yeah,
Sandeep.
thank you
guys.
Thank you. Thank you.
Bye.
Thank you very much, sir. Bye-bye.
Yes, guys. Thank you.
Thank you. Bye-bye.
Thank you.
Sandeep, Prakash, how to go off YouTube?
Leave. What up? Leave.